Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Thank you for joining us for the 45th and final day of the 2020 Peer-to-Peer Global Dental Interdisciplinary Summit. Today we have two special guests in our final webinar. Dr. Audrey Boros and Dr. Keyvan Javid, who will be hosting the session, one of our regents. Thank you for joining us.
Yeah, hi. Thank you, Dr. Shah.
Hi, thank you for having us.
Yes, it's quite an honor. And I must say that you are one of the last specializations that we did not have in our multidisciplinary approach from the entire spectrum of the different disciplines. And pathology, which is a very important topic, and Dr. Javid will inform us a little bit more formally on your bio. All of you that have tuned in the last few weeks, in the last 6 weeks, and have listened to the lectures, thank you for joining us in this monumental effort. We reached over 2 million peers last night and achieved the unachievable together in writing history and in bringing information and knowledge to our colleagues from the most distant places. With that said, Dr. Javid, you have the floor.
Thank you, Dr. Shah. Well, friends and colleagues, thank you and welcome to, I would say, one of the more exciting topics of our seminars today. You know, oral pathology, I find very exciting. You know, a lot of times we tend to overlook, and you know, I know Dr. Boros on a personal note. Dr. Boros has one of the most successful pathology labs in Los Angeles, so we've been using the services for decades. And I know many other professionals who've been using her services. So Dr. Boros, thank you. Also, Dr. Boros is very active. Dr. Shah is sharing our this is the latest one of the latest articles we had. I'm really proud of this. It was published in Compendium. Thank you, Dr. Boros, for all the hard work, and we really appreciate that. So, Dr. Boros, I'm going to go ahead and basically introduce you, Dr. Boros. Thank you for taking our invitation and doing for us. We really appreciate that.
Of course, thank you so much for the opportunity.
Thank you, Dr. Boros. So, Dr. Audrey Boros graduated from Macule University with a Bachelor of Science in Anatomy and Cell Biology. She continued her studies at Queen's University, earning a Master of Science in Pathology and Molecular Medicine. She received her Doctor of Dental Surgery from the University of Southern California, USC School of Dentistry. Following graduation, Dr. Boros pursued her interest in oral maxillofacial pathology at New York Presbyterian Queens. And then she's a diplomat of an American Board of Oral Maxillofacial Pathology, a fellow of the American Academy of Oral Maxillofacial Pathology. She's the laboratory director and the president of Oral Pathology Associate in Los Angeles, and practices clinical oral pathology in Santa Monica. As an assistant professor at USC Austria School of Dentistry, she directs and instructs both predoctoral and postdoctoral courses in oral pathology. In her spare time, Dr. Boros enjoys maintaining an active lifestyle, being outdoors, and spending time with her family and friends. And we know you're taking time from your family and friends, so we really appreciate Dr. Boros. So thank you.
Of course, yeah. Thank you so much for having me. This is so exciting. I'm really grateful for the opportunity, and yeah, we will get started then. So I'll go ahead.
Thank you.
And share my screen. Okay, so today's topic is we're going to start kind of slowly. The topic is learning the basics through cases. So we're going to talk a little bit about approaches to identifying and describing lesions, coming up with differential diagnoses, which is really important to have an idea of what you're looking at when you see an abnormality in the mouth, because that helps you communicate with other clinicians, with the patient, and then also helps guide your approach to the lesion. So we'll learn a little bit about that, and then I'm going to give you examples of interesting cases that in some instances have mimicked more basic lesions, and so it'll be a nice kind of tying everything together. Okay, so first steps is we have to obviously be able to recognize abnormal. As dentists and specialists, we're so focused on our specific areas in the mouth. Sometimes we forget to look and remember that there's more than teeth in the mouth. So we want to make sure that we do our oral screening exams on every patient. At least every 6 months, if possible, when you see the patient on a regular basis. So recognizing abnormal is the first step. Then describing the lesion and generating a differential diagnosis. So that's kind of the things that we're going to focus on. Definitive diagnostic procedures, mostly in the oral cavity, we're dealing with scalpel and punch biopsies. And then, depending on the diagnosis, that will dictate the treatment, and clinical follow-up is also very important. So talking now a little bit more specifically about describing the lesion, things that we want to consider when we're looking at lesions and describing lesions are the location. Basically, what we're trying to do is describe a lesion to somebody, say that's not, that's away, you're talking to somebody over the phone, and you need to be able to describe to them, a good example of what you're seeing. So, they have their eyes closed and they can picture exactly what you are seeing. So location is very important. Color, size of the lesion, the shape, the texture of the surface, that helps dictate a little bit down the line when you're coming up with a differential diagnosis, where you think the lesion might be coming from. And we'll talk a little bit more about that. The consistency of the lesion, is it doughy? If it's doughy, potentially in yellow, we might think of something like a lipoma. And then the growth pattern. So those are all things that you want to consider when you're looking at an abnormality in the mouth. Don't forget about asking the patient questions regarding the history of the condition. How long has it been there? Is it associated with any symptoms? If it's painful, what's the quality of the pain, the quantity, the duration? Is there a history of trauma? And then, especially with some of the disqualmative type gingivitis that we'll get into a little bit later in this presentation, it's really important to include medical history and medications of the patients. And I'll go over why that's so important in those slides. And then social history, obviously also very important, particularly if you're looking at a red or white lesion. You want to make sure that the patient's smoking history, for example. That would be very important. So we're just going to go over some basic descriptors just to get everybody on the same page. So we have here a papule, which is defined as a solid swelling that's less than 5 millimeters. Here are a couple examples on the skin. And this one's on the lower lip. When you have a solid swelling that's larger than 5 millimeters, we call that a nodule. So here's an example, most probably of a hyperplastic lingual tonsil. We can further describe nodules based on their base. So do they have a broad base? If so, we call that sessile. And here's a great example of a submucosal large, say 4 by 2 centimeter sessile nodule of the left hard and soft palate. And then if it has a narrow base, we call that pedunculated. So something like a denture papilloma. If it's papillary, it will have many surface projections, and here are some good examples of biopsy-proven papillomas. Some of them have nice long finger-like projections, others have more of a cauliflower-type appearance, the soft palate being one of the more common locations. And ulceration is defined as an area devoid of epithelium. So we have our mucosa under the microscope. I'm looking and I'm seeing stratified squamous epithelium here, and then all of a sudden we have a lack of epithelium. This is an important concept to understand because when you're taking a biopsy of lesions, you want to know what the most representative sample will be. And when you're approaching an ulceration, you want to make sure that you're including not only the ulcer, but perilesional tissue. And that's not always the case with biopsies. Say, for example, if we back up a couple slides and we see this large sessile mass, the best place to biopsy this would be right in the center and go down as deep as you can. We don't need to see normal or surrounding tissue unless it's an ulceration or a vesicular bullous type disease. And that's also why it's important to have a differential diagnosis. A macule is a flat pigmented lesion. So here we have 2 examples of biopsy-proven melanotic macules. Vesicles and bulla, those are fluid-filled lesions. We've got small vesicular lesions here, and then a larger bulla here. And so this is the basis of vesicular bullous conditions. That's why we call them that, because we're basically grouped into how they look clinically. So vesicular bullous conditions, remember, include pemphigus and pemphigoid. Just touching on imaging, remember diffuse, radio opaque. So radio opaque obviously being more dense than the surrounding tissue, and diffuse not having very well-defined borders and covering a large area. This is specifically what we call a ground glass appearance, and this was fibrous dysplasia. And then remember mixed, radiolucent, radio opaque. So you want, when you're describing imaging, we want to include the type of image. This is a periapical film showing. And then we want to include the borders, so well-defined, and if it's well-defined, is it corticated? And cortication usually indicates the lesion's growing a little bit slower. So well-defined, corticated, and then we go into the internal structure. So here we have a mixed radiolucent, radio-opaque lesion, and then location, and then effect on surrounding structures. So those are all things we want to describe in radiographic appearance. Here we have a nice example of a radiolucency with a nice corticated border, indicating slow growth and that the body has had time to wall off that expansile lesion. And this, under the microscope, would appear like dense bone, that white line. Multilocular, you have obviously multiple locules, and so you have a whole differential diagnosis that goes with multilocular lesions. And so now we're just going to talk a little bit about differential diagnoses. So when we come up with a differential, I'd like to teach to the residents and the students, there's 2 broad categories that you have to think about. So you have to think about what is the etiology of this lesion. And then we subclassify etiology based on whether we think it's developmental. Developmental would have features like possibly most commonly presenting in a younger child, having multifocal areas of involvement or symmetry, bilateral type appearance. We think of things like syndromes, for example. So that would fall under the developmental condition. Reactive, there are several subcategories in reactive. We think about traumatic, inflammatory, infectious, and autoimmune. And then neoplastic, black and white, benign, malignant. In real life, there is a whole, pathology is not black and white. There's a whole area in between benign and malignant that could be benign aggressive or low-grade malignant, or even sometimes we don't even know, we don't even have a name for these things, so we have to come up with these nice descriptive diagnoses. So that's one really important consideration when you're thinking about your differential diagnosis. And the second one is anatomy. So you want to make sure that you're thinking about the tissue type that's present. And that's where a little bit of background in histology and pathology can come in useful. We're all experts in the head and neck area, but think on it for this purpose, think on a tissue level. So say, for example, you have a lesion of the lower lip, and it's a submucosal mass. You want to think about the tissue that's in the area. So you've got fat in the area, you've got adipose tissue, you've got fibrous tissue, you've got minor salivary glands. So all of these things are very important. And then if you think it's a solitary lesion and is fast growing and it's ulcerated, you might think it's more aggressive. So then you would favor a neoplastic, maybe malignant lesion, and then you can base your differential diagnoses off both of those things. So for example, an adenocarcinoma. So that's how I approach differential diagnoses. So we're going to get into some cases. And again, you know, this is a presentation where I like to go over some of the basics through the cases, but a lot of the times these cases, just for interest's sake, these cases are going to be a little bit interesting and kind of mimicking benign lesions, if you will. So let's go ahead with our first case. So in this instance, we're going to cover, you know, red and white lesions. So here we have a 50-year-old female, and this case came to my lab a couple years ago, and the prior clinician had performed a brush biopsy, and this was interpreted as negative. So here we have the lesion on the right lateral border of the tongue. It's fairly large. It's not even all included in the picture. It extends even farther than the photograph. We see that it's irregular surface with some red and white areas. The patient was placed on recall every 6 months because the brush biopsy came back as negative, and so, you know, they were comfortable. They had, I guess, in retrospect, a false sense of security with that diagnosis. Eventually, the patient did seek another clinician's opinion and had another biopsy, and at that point, it was a scalpel biopsy, and we'll talk about why the two it's important to follow if you are going to do a brush biopsy, which in general I don't recommend for oral lesions, why it's important to follow up with a scalpel biopsy, which is the standard of care. But before we get into that, I just want to touch on white lesions and red lesions. So remember, a white lesion in the mouth, it can be defined as a leukoplakia according to the WHO. If it is a white lesion that cannot be scraped off, so we're eliminating Candida in that case, and cannot be diagnosed clinically as any other disease. So that's the strict definition of a leukoplakia from the World Health Organization. When we say it can't be diagnosed clinically as any other disease, we're kind of eliminating some of the developmental and reactive conditions, such as, say, white sponge nevus, which is a developmental condition, or sometimes lichen planus, which is a reactive condition. So a true leukoplakia will not be able to be diagnosed clinically as any other disease, and it's not going to be able to wipe off. So here we have a great example of a leukoplakia on the gingiva, and you can see that there's kind of a raised area, and then it's a little bit more rough, and then a smooth area that's a little bit more diffuse. And so the general differential diagnosis for a white lesion is hyperkeratosis, dysplasia, and squamous cell carcinoma. That's kind of my go-to differential. Remember, hyperkeratosis is just too much keratin on the mucosa, and you can think of it as being analogous to a callus on the skin. So it's kind of a protective thing in general. Epithelial dysplasia is a precursor to squamous cell carcinoma, and at this point in time in the oral pathology world, we are diagnosing these as mild, moderate, or severe. In the general pathology world, it's more low grade versus high grade, and I think we might trend towards that general direction in the next couple years because it is somewhat subjective. And then squamous cell carcinoma, obviously, that's what we're concerned about. So we want to always catch these lesions, if we can, a little bit more, you know, as early as possible, where they're, you know, dysplastic as opposed to squamous cell, because that makes a big difference as far as treatment for the patient. Okay, sorry. Just wanted to cover why white lesions look white. And as I said before, it's because of that thickened layer of keratin. So here we have stratified squamous epithelium. We've got all the individual keratinocytes, and a normal amount of thickness of keratin is this area right here. When you have some kind of a trauma, or even sometimes undetermined significance, you can have a thickened keratin layer, and so that's why the tissue looks white in the mouth. Red lesions, very similar differential diagnosis. Again, an erythroplakia defined by the WHO is a red lesion that cannot be attributed to any other condition clinically, and it doesn't wipe off. And so here's a great example of an erythroplakia. And so our differential diagnosis would be something reactive, so trauma or inflammatory. It could also include vascular lesions. So you've got to start thinking about why the tissue looks red. Sometimes it's inflammation, sometimes it's vascular, and other times it's because of increased thinning of the epithelium, which happens a lot of the times in advanced dysplasia. And sometimes it's a combination of all three. So our differential for erythroplakias are dysplasia, squamous cell, and something reactive. It's also important to note, remember, and I'm sure you're all familiar with this, that erythroplakias are usually more, if they're going to be dysplasia, they're more advanced than leukoplakias. The reason being that the more advanced the dysplasia, the less differentiated the cells are that make up that mucosa. And so they kind of, if you will, lose their ability to produce keratin, and that decreases that layer on the top, and so therefore the tissue looks a little bit more red in combination with potentially inflammation and increased vascularity in the area. So just to, I won't focus too much on histology, but just so you can get an idea, we've got mild dysplasia, which is abnormality in the cells and architecture of the reedy ridges in the lower 1/3 of the epithelium. And then moderate we define as about the lower half, and then severe more than 2/3, and then carcinoma in situ would be full thickness but not yet broken through the basement membrane. And that's really important concept to understand, because if you have carcinoma in situ, it's basically the step before cancer, but it's not able to access the connective tissue, which is underneath the epithelium, which is separated by this basement membrane. And that's really important because there's no blood vessels in the epithelium. They're only in the connective tissue and lymphatics. And so once these abnormal cells access the connective tissue, then they have access potentially to the vessels. And that can result in metastasis, which is, the reason for a lot of the times the mortality associated with cancer. So this is just a kind of more of a diagram for those that aren't too versed in histology. The diagnosis in this case, so as I said, the patient sought a second opinion, had a biopsy, a scalpel biopsy, and the diagnosis was a squamous cell carcinoma. So just to talk a little bit about, brush biopsies in general, I don't recommend them in the oral cavity. They're great for, say, areas that are a little bit more difficult to access, like the cervix. We use them for pap smears, but in the oral cavity, the standard of care really is a scalpel or a punch biopsy. There's just a lot of false negatives associated with a brush biopsy due to, the way that the slide is, processed and analyzed at the labs, as well as user error. So you might not scrape the right area, or you might not scrape enough tissue. So, there are a lot of steps where you could potentially have a false negative, which happened in this case. So the patient was followed, for several months or, almost a year, without addressing the lesion because there was a false sense of security. So you just want to avoid that, obviously, for the patient's well-being. So in general, scalpel biopsy, include the red and white area. Remember, the red is usually more advanced than the white. So this patient was diagnosed with a squamous cell. We're just going to talk a little bit about squamous cell in general. As you can see from my heading here, I've separated into oral cavity and oropharyngeal, and that's really, really important. The reason being that the more, we're learning about these two diseases, the more we realize that, even though they're squamous cell carcinomas, they're actually very separate types of squamous cell carcinomas. We know that the oral cavity usually is, squamous cells are associated with smoking and alcohol in combination, even more so. Betelquid in some areas of the world, as well as chewing tobacco, sunlight on the lips. But then when we look at the oropharynx, that's more so associated with HPV. So The farther back you are in the throat, in the oral cavity, the more likely it will be the squamous cell will be HPV related. The more anterior you go, the less likely. So just backing up here, talking about the epidemiology, within the United States, about 53,000 cases estimated per year. We still combine the data, so that's data combined between oral cavity and oropharyngeal squamous cell. But I think in the next couple years, you're going to start to see the data start to kind of split up, because they really are different types of squamous cell, and there's a different prognosis as well, which is really important. So, this data here is still combined. Estimated 10,000, almost 11,000 deaths per year. Males are affected almost twice as commonly as females. 5-year survival rate combined is 62%. And it's the 8th most common cancer in men. But like I said, if you look specifically at the oral cavity versus oropharynx, oropharynx in general will have a better 5-year survival rate if it is HPV related. So this is a hot topic right now. Again, in the States, 80 million total HPV infections, 6 million new infections per year. 80% of Americans will have HPV in their lifetime. Most of us will be clearing these infections without consequence, but there are a subset that will develop an HPV-associated malignancy, and 1/3 of those, and this is rising, so head and neck squamous cell carcinomas are increasing when they're associated with HPV, and cervical cancers that we all know are also associated with HPV are on the decline. And actually, this year is when oropharyngeal, the number of oropharyngeal HPV-related squamous cells increased higher than the number of cervical cancers related to HPV. So that's really important. So HPV is a virus. There's many different subtypes of the virus. There's low risk and high risk, or non-oncogenic, meaning low risk, and high risk or oncogenic subtypes. And that's really important to know, because the low risks are associated with things like papillomas and condylomas, and the high risk subtypes are what are associated with the squamous cell carcinomas. We kind of went over this already, but just to kind of drive it home, looking at this picture, we see that the oropharynx is defined, if you strictly define it as the soft palate, the tonsillar pillar in the back of the throat, as well as the base of the tongue. 80% of squamous cells that arise in that area will be HPV associated. If you define the oral cavity as everything anterior to that, only about 2 to maybe 5% will be associated with HPV. So our high-risk sites for squamous cell carcinoma are still the same. So lateral borders of the tongue, ventral tongue, floor of mouth, soft palate, tonsillar pillar. But we know that kind of the soft palate, tonsillar pillar area, those would be HPV related more likely than the former locations. So just a little bit about oropharyngeal squamous cell carcinoma and HPV. We had a study here that was done in 2011, which is kind of, at the beginning of when all this was starting to come to light. This study found that not only was the incidence of oropharyngeal squamous cell carcinoma increasing, in this case they found a 30% increase, but if you look at some of the newer studies, it's a lot higher increase than that. This was primarily in younger men and often diagnosed at late stage. So they found the incidence was increasing, but also the proportion of HPV positive oropharyngeal squamous cell carcinomas was also increasing. And so they basically took biopsy samples from the 1980s and analyzed them for HPV DNA, and then they compared that with biopsy samples from the 2000s. And so they found that in the 80s, only 16% of those samples were HPV positive, whereas in 2000 it was 73%. So there's really an increase in the proportion of HPV positive oropharyngeal squamous cells as well. So this is something that I'm sure that some of you have come across in your practice already. This is a study that was published in the New England Journal in 2007, one of the first studies addressing this topic. And so Dr. D'Souza, showed that there were several really important independent risk factors. She showed that the increased number of vaginal or oral sex partners was associated with developing oropharyngeal squamous cell carcinoma. that the presence of HPV-16, regardless of alcohol or tobacco use, was also associated with the disease. And that was very important because that was one of the first times that somebody was able to show that it was actually the virus and not other tobacco and alcohol related condition. And then engagement in casual sex at an early age was also defined, or was also an independent risk factor for developing oropharyngeal squamous cell. And this was also very interesting. We heard this at a talk that she gave at our American Academy of Oral Pathology a couple years ago, and she basically showed, or her data showed that sexual partners with a history of HPV-associated cancers, she showed that if a patient's partner had a history of a HPV-associated cancer, that individual was at increased risk. So for example, if the patient's, say, wife had a history of cervical cancer, then that the husband would have an increased risk of developing an oropharyngeal cancer, which is really, really interesting. So her data basically showed that oral HPV infections sexually acquired, and that there was an association with oral genital contact and development of oropharyngeal cancer. And here's a really good example of what an, not super advanced, but not early as well, lesion. This was biopsy-proven HPV-associated oropharyngeal cancer, where we see this kind of papillomatous-like lesion or verrucopapillary lesion here. But if you look closely, it's probably extending into the surrounding areas as well. So that's a good example of what you might be looking for in your clinical exams. I'm just gonna contrast oral versus oropharyngeal lesions in the next couple slides. So remember, for oral cancers, same kind of demographic, older males, smokers and drinkers in general. For oropharyngeal, it's increasing in younger males, and it's HPV associated. So here we have this kind of granulomatous erythematous lesion of the oropharynx, and that's typically what we would be looking for in an oropharyngeal squamous cell that was biopsy proven. And this is something that we would consider to be very suspicious for squamous cell in the oral cavity, and that was also biopsy proven. Here are a couple other examples. So non-HPV related squamous cell carcinoma, you can tell this is kind of a younger female, which is interesting. And then here is kind of a middle-aged male with a HPV related squamous cell. So these are the lesions, try and, when you're doing your exams, make sure you're not only looking at all the areas in the mouth, but make sure you're looking at the oropharynx as well. When I'm practicing clinically and I even see a tonsillar asymmetry and there's no history of a recent upper aerodigestive tract infection, I will refer to ENT just to have the patient scoped, because there are a couple of things on my differential diagnosis, including very early squamous cell, as well as lymphomas that can look like that can appear as tonsillar asymmetry in the very early stages. Here's another example. This patient was diagnosed with having localized aggressive periodontitis. The tooth was pulled and an implant was placed, and the crown was placed. The implant crown was placed. The clinician was thinking all along this was granulation tissue. So, a couple of things. You notice that the rest of the oral cavity, the hygiene looks very good. So remember not to jump right away to things that you are most familiar with. If it's not quite fitting, make sure that you're taking a biopsy to rule out other more serious conditions. 99% of the time it's going to be, a high percentage of the time it will probably be nothing, but it is a good idea to make sure you know what you're dealing with. So this is all a squamous cell carcinoma, and it was never periodontitis, because squamous cell can mimic periodontitis. Here is another example of an HPV-related biopsy-proven squamous cell carcinoma of the oropharynx. This is also a really great case that came to the lab. Here we have, I like to, in my full screen presentation, I don't have all the pictures up at once. I kind of click so you have a chance to figure out where you think this squamous cell is. but it's outlined here. I nicely outlined it. This is squamous cell carcinoma. It's masquerading as periodontal disease. So for cases like this, you're not going to jump to, oh my gosh, this is a squamous cell, but you should have a high index, you should start to think about maybe think outside the box when you're scaling, root planing, treating this as periodontal disease, but it doesn't resolve. That's the key. It's okay to approach this with the normal periodontal measures, but if it's not responding, that's when you've got to start thinking outside the box and take a biopsy. Here's another example of a patient, a young female, and she had this lesion that the dentist actually was suspicious because she had very good hygiene. And so a lot of the times people might think of a pyogenic granuloma or some kind of reactive gingival nodule. More so here, when you start to see the ulcerative lesion here, you should have a higher index of suspicion that maybe something more ominous is going on. But this was a biopsy-proven squamous cell carcinoma in a young patient. So, remember, it's okay to scale the area, try and identify a local irritating factor, but if it is not resolving as you would expect a reactive condition to resolve, it should be biopsied. You don't want to delay that for the patient's sake. Here's a more obvious squamous cell carcinoma of the gingiva, kind of a red and white, large. I'm hoping all of you would be highly suspicious. These are some of the patients I saw in my clinic. This patient, she had been to several clinicians, and she was just very scared to get a biopsy. Eventually, we did convince her to take the biopsy, and that was a squamous cell. This patient, very interesting case, we took a biopsy. It was the squamous cell carcinoma. She had lymph node involvement, but when they sampled the lymph nodes, it was actually an ovarian cancer that had spread from her ovaries to her lymph nodes. So she had squamous cell and ovarian cancer simultaneously, which is really interesting. So just to finish up this case here, looking at the 5-year survival rates, I like showing this slide because it kind of highlights that, say if you look at all stages and you look at breast cancer, we've got colorectal, melanoma, and oropharyngeal squamous cell. If you look at all stages, you see that, say for example, melanoma has a much higher 5-year survival rate overall than oropharyngeal squamous cell. The reason, when you look at the numbers, you see that the local disease, which means the primary site, regional disease is lymph nodes, and distant disease is where it's metastasized. The overall number here reflects the local disease. And so that means that, dermatologists and patients in general were getting these pigmented lesions removed early, and most of these lesions are surgically cured at the local stage. We cannot say the same thing for oral and oropharyngeal cancer. Closer to the regional 5-year survival rate, that's 65%, and that's because by the time we find these lesions, most of the patients will have lymph node involvement. And so I just like to show this because it highlights that we really need to do our part as what we can control is making sure that we're doing our exams and addressing any lesions that we find. And that's the only way to really increase that 5-year survival rate. Okay, last little bit on the squamous cell and leukoplakia before we move on to our next case. This is really interesting to me because I see a lot of gingival dysplasias in squamous cells. I would say anecdotally, it's almost to the point where it's similar in my region to, similar in number in my region to tongue squamous cells. It's definitely increased over the time I've been practicing in LA. And so here is an example of a leukoplakia that's multifocal. So here we have this area here. Differential diagnosis. I would say a couple good, so one thing that you might consider would be Candida, okay? How we can quickly eliminate that would be to see if it wipes off. In this instance, it doesn't wipe off. The second differential I would consider would be something like gingival lichen planus, and it can look a lot like this. The thing that I notice is there's no cheek involvement. You don't always have to have cheek involvement, but it kind of fits for something reactive or autoimmune because it's multifocal. The thing that I don't like that doesn't quite fit for lichen planus is that it's a little bit bumpy, and we call that verrucous. And so when I see that and I see kind of multifocal areas with sharp definition, I'm suspicious for leukoplakia, even though it's multifocal. And so we took a biopsy of this lesion. Here's another example of the same condition that's presenting a little bit differently. So it's a white kind of line that's spreading along the gingival margin, a little bit verrucous here again. You might think initially of some kind of trauma, like the patient was wearing bleaching trays and bleached her gingiva, but it's been there for several months. It's asymptomatic. This is another case of this condition, and here is a more advanced case of the same condition. So we're kind of going from early to medium to later involvement of the same condition. So we've got white, diffuse involvement, verrucous type appearance. It looks like it's proliferating. And it's spreading all over. So this is something that we call proliferative verrucous leukoplakia. And it's something that, like I said, I'm seeing a little bit more of increasing in the recent years. And I'm not quite sure. We don't know what causes it. We don't know the etiology. We just know that it usually presents in elderly females or middle-aged females that don't have the high-risk behaviors or high-risk tendencies for smoking and drinking. This is that same patient where we have the white lesions that usually start for whatever reason on the buccal gingiva, go through the interdental papilla onto the lingual, and then here we have it spreading diffusely onto the buccal mucosa. So PVL, I put it as a hot topic because, again, anecdotally, I'm seeing more and more of this. It's multifocal. It's not typically presenting like your normal leukoplakia, which is usually one area. Here we've got it multifocal, and it is pre-malignant. So it's in this stage, in the early stage, it's dysplasia or even just hyperkeratosis. Then it goes to dysplasia and then eventually squamous cell carcinoma. So it's defined as having a progressive clinical course. So it starts in one area and it spreads along. And it changes over time, so it might start flat and then become bumpy, and then it has the highest potential of any other condition to develop into squamous cell carcinoma. And this is just kind of what I was saying, but a picture of that. We see it most commonly on the gingiva. It occurs in this unique group of patients, elderly or middle-aged women who do not have the history of tobacco or alcohol use, and we don't know what it's caused by. It doesn't seem to be HPV related or any kind of virus that we can identify, and this is another typical example. And another example here as well. Treatment, we don't really know how to treat it, which makes it complicated. You can some clinicians will, remove the tissue, the worst looking areas, but it tends to come back. Laser excision may help delay progression, but now there's even a little bit of newer literature that states that it actually might make it a more aggressive when it comes back. So that's controversial. Most of these patients will develop a squamous cell within 8 years, and it has the highest potential for malignant transformation. So here are the secrets to success for this case. Look for white and red lesions. Squamous cell carcinoma has two demographics now that you need to be aware of: older men, smokers, drinkers, and younger men, non-smokers, non-drinkers. Those would be the HPV-associated squamous cells. Okay, so case number 2. The rest of the cases don't take quite as long to get through. So case number 2 is this 60-year-old male. He had an implant placed in the area several years ago that became loose recently. That was removed. It was not painful. The patient had, medical history for hypertension and a remote history of smoking. So here's the example. This is the case, the patient's clinical photograph. And you can see that there's kind of like a granulation type tissue in the area where the implant was removed. This was the implant where before removal, where you can see that there's localized bone loss in the area, this panoramic. So my differential diagnosis when I'm, looking at that photograph clinically would be one of the 3 Ps, and I'm sure you're all familiar with this: pyogenic granuloma, peripheral ossifying fibroma, or peripheral giant cell granuloma. And so they just look like kind of granulomatous type lesions of the gingiva, and that's your go-to differential for lesions that are similar appearing to that. They're reactive. You need to biopsy them for confirmation, and excision is usually curative, but sometimes they do recur if the eliciting factor is not completely removed, such as a piece of calculus or something some foreign material. The biopsy in this instance, we can see that we have a diffuse proliferation of these purplish infiltrate of cells, and when we look on higher power, we actually see that these cells are highly atypical with ringed mitoses, many different number of mitoses. And so this was actually not one of the 3 Ps, even though it mimicked one of those 3 Ps. This was the patient's initial diagnosis of having a lung cancer. So this patient was worked up, found to have lung nodules, but the initial diagnosis was based on the oral biopsy. It's unusual, but it does happen. And I like to present this case because it mimics one of those 3 Ps. So this was a metastatic adenocarcinoma, and the patient was found to have left lung involvement, responded to chemo, and as far as I know, the patient is alive and on maintenance chemotherapy. Just wanted to touch on metastatic disease to the oral cavity. Here's another example that looks similar to a pyogenic granuloma, or one of the 3 Ps. You do have to biopsy for confirmation. This happened to be a GI malignancy. This patient had a cutaneous melanoma, and so this was metastatic melanoma to the oral cavity. So in general, if you're going to see metastasis in the oral cavity in the soft tissue, you'll see it present like a pyogenic granuloma or something similar on the gingiva, but it can also present centrally as well. And the most common metastases to the oral cavity are the breast, lung, kidney, thyroid, prostate, GI tract, and skin. Usually you will have, depending on how advanced the disease is, you may or may not have pain. This patient did not present with pain, but there was bone loss and a swelling, associated swelling. If it is central, you can have pathologic fracture. Sometimes these lesions are just completely asymptomatic, like in this case. And if it's going to involve the central location, it will involve usually the mandible. And something to consider is what we call numb chin syndrome. If you've got a patient that develops numbness in the mental nerve area, that's something that the patient needs to be worked up for. Just going to go ahead and skip to this here. I like to show this case because it highlights, again, kind of a benign appearing lesion where the clinician was, considering one of the 3 Ps until they did a flap and they found a lot of bone loss. And peripheral indicates that it's should not have bone involvement, means it's limited to the peripheral tissues like the gingiva. So if you have a lot of bone involvement and you're thinking 3 Ps, probably not going to be one of those because you shouldn't have central involvement. Here you have a lot of bone loss. This was biopsy-proven lymphoma. These are examples of squamous cell carcinomas that are kind of mimicking the pyogenic granuloma. So squamous cells can mimic a lot of other things as well. Periodontal disease and pyogenic granuloma. Here are the secrets to success. Just keep in mind that malignancies can mimic benign lesions like those 3 Ps. The gingiva is the most common soft tissue site for metastatic disease and tends to involve these primary types of malignancies. Okay, so case number 3. Here we have a 60-year-old female, and she presented with intermittently painful gingiva of 1 year duration. It's not uncommon for me to see these patients presenting, to my clinic with having a long history of painful gingiva and going from doctor to doctor. So, because you see this picture and you see a lot of calculus and plaque, and you're thinking, oh, this is probably just gingivitis related to this buildup. But actually, if you hear the patient and she's saying it's painful, potentially what has happened here is that she is too painful to brush. And so she is not brushing properly because it's too painful, and that's why she's getting the buildup. So Just keep that in mind. Think outside the box if you see patients like this. The differential diagnosis for this erythematous type appearing gingiva is what we call Disqualmative Gingivitis. The differential of the lesions includes erosive lichen planus, lichenoid gingivitis, which is kind of an allergy and is mimicking lichen planus, and then the vesicular-bullous diseases, so pemphigus and pemphigoid. More and more, I am recommending, in addition to doing H&E biopsies, especially if it's a biopsy of the gingiva, to also include a direct immune fluorescence for diagnosis, because like you see here, this is the biopsy that we got. It's a good biopsy. You can see the split, but you see that there is a split with some hydropic degeneration, which we see in lichen planus, and a subbasilar split, which we see in pemphigoid. So sometimes there are overlapping features. This is pemphigoid, this is lichen planus. So you can see that there is an possibility for not being able to give a definitive diagnosis on H&E alone, especially if it's from the gingiva. So I do like to recommend direct immune fluorescence. So your normal H&E biopsy will go in formalin and your DIF will go in this Michelle solution. You cannot put a biopsy in formalin and ask for a DIF. It has to be in Michelle solution, so you've got to be organized with that. DIF is a technique where you have antibodies that are highlighted, and you use a specific fluorescent microscope to view those antibodies, and depending on where they're deposited, it will infer the different diagnoses. So if they're deposited along the basement membrane, then it would be pemphigoid. If you have deposition throughout the epithelium, that indicates that the antibodies are reacting to desmosomes, and that would be pemphigus. There's direct and indirect subtypes. Indirect just means that you're taking it from the patient's blood. Direct means that it's a biopsy. And you can't usually indirect is limited to pemphigus, but some labs are now starting to, are able to do indirect immune fluorescence for pemphigoid as well. And this was her example, this patient. So you see linear deposition of IgG along the basement membrane, and C3 here as well, which is a complement protein. And so she had mucous membrane pemphigoid. So I like to show this case because pemphigoid and the Disqualmative type gingivitis, they can mimic regular gingivitis, especially if it's painful for the patient and they can't brush properly. Pemphigoid is an autoimmune mucocutaneous condition, so it involves the skin and the mucous membranes, and it is chronic, so it's not something that we usually attain a cure for. It's something that waxes and wanes, usually seen in females, oftentimes painful, with or without vesicles, predilection for the gingiva, and you do need a biopsy to definitively diagnose that. It's important to remember that pemphigoid can affect any mucous membrane, including the eyes. And so when you have a diagnosis of pemphigoid, it's very important for these patients to be seen by ophthalmologists and treated as needed, because it can lead to scarring and blindness if left untreated. Just going to show you a couple other examples of entities in that Disqualmative Gingivitis rubric. So lichen planus, biopsy proven, very erythematous gingiva, and also had the nice Wickham striae. One thing to remember for lichen planus is most of the times, if not all of the times, it's going to be a multifocal disease. So that's very important when you're developing a differential diagnosis to consider. If it's a solitary white and red lesion, probably shouldn't have lichen planus at the top of your diagnosis. If it's multifocal, then you would favor lichen planus. These are Disqualmative type gingivitis as well. This is lichenoid gingivitis secondary to the amalgam that's placed here, which was replaced, and then this was resolved. This is a patient that had lupus, and lupus can look a lot like Disqualmative gingivitis in the mouth. So it's very important to include the medical history of the patient to the pathologist so we can look for very minor differences histologically between the two, because otherwise it's very easy to overlook these little differences. And as you can see here, lichen planus, lupus, has a very thickened or a slightly thickened basement membrane, and that's one of the things that we look for. So there's a lot of histologic overlap. So secrets to success here: serious conditions can masquerade as gingivitis. You know, it's okay to approach the lesions initially like they might be related to periodontal disease, but if they're not responding like you would expect, then think outside the box and either do the biopsy or refer for biopsy. Okay, here is case number 4. We have a patient that presented to this clinician, and she described a sense of fullness in the area. I usually just show this picture here and try and have people consider where they would think the lesion is before showing where the lesion is. I like showing this case because it's so subtle, but it also highlights the importance of having to palpate. This doctor not only looked, but palpated the area and was able to feel something submucosally. Otherwise, it's very, very subtle. And so this clinician, excellent clinician, did a biopsy. Your differential diagnosis here, if you think about the tissue types that are there, you definitely have salivary glands in the area. So for this location, the palate, you would include both a benign and a malignant salivary gland lesion, just based on statistics with that location. And then, you know, a benign soft tissue tumor, for example. We took a biopsy, and this patient had an adenoid cystic adenocarcinoma. So here histologically, we just see the features of this diagnosis, this kind of a Swiss cheese appearance that we like to call this pattern. And this is a very aggressive malignant epithelial salivary gland neoplasm. It tends to grow slowly, but it can mimic a benign tumor clinically. Clinically, we see it affecting the major glands slightly more often than the minor glands, but if it's going to affect the minor glands, the hard palate is the most common site. Women are affected more commonly than men, and usually middle age. So here we have, the next picture is going to be a little bit startling. So here was the biopsy and the patient's diagnosis, and this was for treatment. And so you can see that it was very serious. It was probably, you know, maybe even involving the maxillary sinus. And so this patient has to have a wide excision because of the aggressive nature of the lesion, and now she has an obturator, and as far as I know, she's doing well. Just going to cover some salivary gland tumor data. More common in women, in Caucasian women, with a 2.5 number of cases per 100,000 individuals. Overall, benign lesions are more common than malignant lesions. But if you break down by site, more common in the parotid gland, and the next most common site would be the intraoral minor salivary glands. Remember, we have minor salivary glands everywhere in our mouth except the attached gingiva. Usually we do not have them there. If you break down just looking at minor salivary gland tumors between benign and malignant, we've got about a 50-50 chance overall. And if you further break down by site, more common to have malignant tumors involving the retromolar pad, the tongue, the floor of the mouth, and the lower lip as well. And here's a great example of something that a lesion that might be mimicking a mucocele or a hemangioma, and this was a mucoepidermoid carcinoma. So remember, in this location, if it's going to be a salivary gland tumor, 70 to 90% of the time it will be malignant based on the statistics. Here's another example of an upper lip lesion. It's kind of mimicking a benign submucosal mass, but this was a malignant salivary gland tumor. And then the next, this was a cynic cell adenocarcinoma, and it was early. And if this was a later stage, same diagnosis, but the lesion was not removed. And so they can dedifferentiate and become very aggressive tumors. So secrets to success here, just wanted to highlight that, you know, look when you're doing your exams, but also feel, because lesions can be subtle or deeply submucosal. We've got 2 cases left, and sorry, I'm going a little bit over time. Here we have a long-standing lesion, and the patient had declined surgery several times and would drain the lesion himself. So this is a central lesion, and for all intents and purposes, my differential diagnosis here would be something like a dentigerous cyst, so a lesion that is a radiolucency surrounding the crown of an impacted tooth. And then you also want to include things like odontogenic keratocyst and maybe even an ameloblastoma. You can see that there's some root resorption here, and it's kind of getting a little bit fuzzy at the distal aspect if you look really closely. And so we took a biopsy, and this, here's our differential diagnosis. You could also include a glandular odontogenic cyst. These are examples of dentigerous cysts, so looking very similar. But when we looked at the histology, we saw a cystic lesion. But then when we look a little bit, it's a little bit fuzzy, but when we look a little bit closer at the histology, we're seeing islands of atypical squamous mucosa within the cell wall, within the cyst wall. We saw some mitotic figures and some atypical cells, and there was enough invasion that, and keratin pearls, that this was actually diagnosed as a squamous cell carcinoma arising in a dentigerous cyst. Again, most of the time, these are going to be dentigerous cysts, but it's very, very important to biopsy these lesions because, you know, every now and then you're going to get the zebra, and this, you know, happened to be a squamous cell arising in a dentigerous cyst. Most commonly, the surprises that we'll get mimicking a dentigerous cyst is an odontogenic keratocyst or maybe an ameloblastoma or a glandular odontogenic cyst. So this was a very interesting case. It's very rare, but it has been reported, increasingly reported with long-standing lesions. This patient, remember, had a history of irritating the area by draining it himself over, you know, several decades. That potentially could have helped progress the lesion. But this is a good example of why all cystic tissue really should be submitted, even if it looks routine. And then our last case, we have a 55-year-old male. This was an asymptomatic lesion discovered on routine exam. The clinician, excellent clinician as well, he did a biopsy of these lesions here because he was concerned for the white areas. The patient had a heavy history of smoking, and there was a similar looking lesion on the soft palate. So again, biopsy was taken of this area and this area. And when we looked at the histology, we were pretty floored. This is what normal looks like. This is what this is the biopsy, and we can tell, even not as pathologists, that there's something going on at the interface of the epithelium and connective tissue, and there's some cells that are kind of, you know, spreading up towards the surface. Go on higher power, we can see there's a little bit of pigment, and we have, you know, what we call nests of cells with pigment and some atypical nuclei. And this case actually was diagnosed as a melanoma, believe it or not. I'm going to go back to the initial presentation because I just want to show you how subtle it can be. So there's definitely pigment here, pigment under this white lesion. We initially attributed that to smoker's melanosis. And again, the clinician biopsied this area here and this area here because they were concerned for the white areas being dysplasia. So most of the times, you know, it's not going to be something crazy, but this is a very good example as to why even lesions that can look benign clinically should be diagnosed, because this clinician saved this patient's life by doing that biopsy. Because oral melanoma is aggressive. It's often diagnosed at a late stage. Here it was an early stage. And, you know, if you see, my general rule is if I see a pigmented lesion in a high-risk area, which the high-risk areas are the palate and the maxillary gingiva, if I take an image, radiographic image, and I don't see amalgam in the area, I do recommend a biopsy because, you know, these conditions are very, very aggressive. And even the early stage lesions can look very benign clinically. Here's a later stage lesion where the pigmented lesion is spreading already. Got multifocality here in a high-risk site, also an oral melanoma. This is a little bit more typical for an oral melanoma. And same here. This is a great example of why to biopsy early stage lesions. This was a melanotic macule. This was a melanoma in situ. Same location, very similar appearance. So conclusions here, you know, extraoral and intraoral exams on every patient, every time. That's my rule. I know some people, you know, you're getting into your clinical practice and maybe it's not feasible to do that, but at least every 6 months. Look and feel. So make sure that you're doing a good thorough exam and also feeling and palpating because lesions can, you know, be developing deep in the submucosa. Serious lesions can masquerade as benign, like I showed you today. Remember, for differential diagnosis, think about etiology. So do you think it's reactive? If you think it's reactive, try and eliminate potential sources of irritation. And then if it remains and it doesn't change, that's when you should biopsy. In general, we have that 2-week rule because the mucosa turns over in about 2 weeks. You should give it 2-3 weeks. If it hasn't changed, it should be biopsied. And remember, favor a scalpel or a punch biopsy over a brush biopsy. Brush biopsies just aren't very reliable in most cases in the oral cavity. And that is it for today. So are we going to take questions?
Yes, doctor. Let me bring everyone back into the stream. I just wanted to quickly come in and say that my hats are off to you. I'm not wearing one, but you are an amazing professional. The amount of knowledge that you have and the way you explain it, and that was exhilarating because us general practitioners, a lot of times, we sit there and we look at something and we don't have a clue what's going on because it's long gone from dental school.
Of course.
Just wanted to give you a shout out. Thank you so much
Thank
for that.
you so much. Thanks for having me.
And there's so many questions. I'm just going to pick a few of them here. One of the questions they asked was the difference between developmental, reactive, and neoplastic.
Okay, so that is, we're talking about the etiology of a lesion. Lesions can be, you know, tumors, which is a neoplasm. Tumors can be benign or malignant. Then you can also have reactive lesions. So just thinking about the etiology of reactive lesions, something like trauma, like you bite your lip and you get a fibroma that develops, or a mucocele. And there are other types of reactive lesions like inflammatory, infectious, so like a fungal infection or a viral infection. And then developmental, the easiest way to think about that is something like a syndrome. So sometimes in the oral cavity, you can have multifocal lesions. Usually it's bilaterally symmetric in younger children, and that's when you start to think about developmental conditions like a syndrome. So does that answer your question?
Yes, thank you. So another question, you know, as a general dentist, you know, I do a lot of biopsies. You know, I think one of not enough, definitely. So, you know, I think one of the concern with general dentists is that they don't know how to, and they don't know, like, say, for example, if it was if you have to do a complete excisional biopsy, or you can do a punch biopsy. And then one of the questions here was asking, why do you prefer scalpel biopsy versus brush biopsy? So, I mean, I guess these questions are not really answered. So,
yeah. So, okay. So what a brush biopsy is, it's a little brush, and you basically just touch the tissue with the brush, and then scrape it on a slide, and then you have alcohol that fixes that. And so when you look under the microscope at that, it's just cells kind of here and there. There's no orientation to each other. It's just kind of scattered cells. So you're looking at the cytology of the cells. The reason why you have higher false negative or less reliability essentially is that there's a lot of source for user error. In order to say, if you think about dysplasia, like I said, you have mild, moderate, severe. If you have a white lesion and you brush just the top of it, you're probably only going to get keratin, maybe a couple cells. You're not going to, if it doesn't bleed, you're not going to get the base enough sample. And so if you have, say, mild dysplasia and you just brush the top of it, you're missing the atypical cells in the bottom. And so that would read as normal, but you didn't get the right sample. You didn't go deep enough. Even if you go deep enough and you see atypical cells, the diagnosis could be cellular atypia, but then you don't know if that atypia is because you have inflammation present or it's actually that the cells themselves have become dysplastic. So then you would have to do a scalpel biopsy anyway in order to find that out. And so in general, it's a waste of, it's not reliable and it delays diagnosis oftentimes. And it just costs the patient more money in the end because it's not, nobody's ever going to do a surgery based on a brush biopsy. It's got to be a scalpel biopsy diagnosis.
Absolutely. So just one last question here. So if you were to, so I would say like dentists are probably scared that if it's a malignant cancer and they're going to do a punch biopsy, they could be spreading it, or what would you say about that? And is there any preferred method? I mean, scalpel would be the standard of care.
Yeah, so that's a good question. In general, there is not a lot of evidence to support that you're going to spread the cancer by cutting into it. If it's, say, a metastatic disease, it doesn't matter, right? Because you've got to diagnose it anyway. Even if it's a primary site, the chances of you're cutting into it, causing bleeding, and then some of those cells having the right mutations to get into that bloodstream, but they also have the right mutations to survive the bloodstream, exit the bloodstream, and then set up a colony at a secondary site is so low that it's not considered to be, something that we worry about. We have to get the diagnosis. It's kind of, risk versus benefit.
So absolutely. So go ahead and just cut the lesion out and send it in for a biopsy. That's great.
And remember, if you have a mass, try and get the center of the mass. If you have an ulcer, try and include some periphery of the tissue as well. That's really important. Try and think about where the best sample would be.
Great, doctor. Thank you so much. So informative. So much information to get all this information all at the same time. But thank you so much. We really appreciate you, and thank you for coming on. And I know you're busy, and I hope you have a wonderful weekend, and I'm sure our colleagues are very excited and they enjoyed the lecture very much.
Well, thank you so much for having me. It's always a pleasure to see you, and I hope you guys enjoyed that presentation.
Thank you.
It was,
thank you very much.
Absolutely amazing. Thank you.
Thanks.